BP's only 82/46.
Hey, Mom, you're gonna be okay.
Heart rate's 124.
She's still bleeding higher up in the esophagus.
There's a ton of blood. Oh my God.
Someone please take her out.
Oh.
ICU boarder, 48-year-old cirrhotic, here for hematemesis.
So the patient who was in the ICU developed complications and was brought to the ER. The primary disease here is cirrhosis, which is chronic liver disease where liver tissue becomes fibrotic and nodular, which impairs blood flow through the liver. The backflow in portal vein causes portal hypertension. This backflow and high pressure lead to dilation of portosystemic and anastomotic channels, including that in the esophagus called as esophageal varices near the gastroesophageal junction. Now these esophageal varices could rupture and lead to upper gastrointestinal bleeding where the patient vomits blood, which is called hematemesis. The vomited blood is fresh and bright red blood coming from the esophagus. It's a life-threatening emergency requiring immediate medico-surgical intervention.
Intubated overnight, and after 1 unit, PRBCs and FFP was supposedly stable.
Not anymore. Weak carotid. Shavati, I need you on section.
PRBC means packed red blood cells and FFP is fresh frozen plasma, blood products used here to replenish RBCs and plasma lost through hemorrhage. However, she is in shock now due to the ongoing hemorrhage. Large volume pulse like the carotids are weak, meaning there is severe hypovolemia and could affect brain perfusion.
Why is she bleeding all of a sudden?
Most likely bleeding is from the esophageal varices. With cirrhosis, you get enlarged veins under pressure at the entry of the stomach, varicose veins, and they can burst.
Apart from this, the portosystemic anastomosis can dilate in the anorectal region as well, which leads to anorectal varices, which can also bleed, causing blood in stool called hematochezia. The defecated blood is fresh and bright red, coming from the anorectal region.
What does that mean?
The cirrhosis from the hepatitis B caused a vein to burst where the esophagus meets the stomach, and that's where the blood is coming.
So, the cause of cirrhosis here is hepatitis B. Chronic hepatitis B can lead to cirrhosis over time. Other causes of cirrhosis include chronic alcoholism, which is the most common cause, hepatitis C, non-alcoholic fatty liver disease, autoimmune hepatitis, and so on.
BP's only 82/46.
Hey, Mom, you're gonna be okay.
Rapid infuser, massive transfusion protocol, octreotide bolus and drip, 80 pantoprazole and ceftriaxone.
Treating hematemesis due to esophageal varices includes stabilizing the patient, stopping the bleeding, and preventing recurrence. Initial resuscitation includes IV access with 2 large bore IV lines, blood transfusion with packed RBCs to maintain hemoglobin 7 to 8 grams per deciliter, and also use platelets or FFP if there's evidence of coagulopathy with INR more than 1.5 or platelets less than 50,000. The mainstay of treatment includes the somatostatin analog octreotide, which decreases portal pressure by vasoconstricting splanchnic blood vessels. The decrease in portal pressure would also decrease the blood flow towards the anastomotic channels and hence decrease variceal bleeds. An IV bolus of 50 micrograms is pushed once, followed by continuous IV infusion at the rate of 50 micrograms per hour for 3 to 5 days. It can be discontinued once the bleeding is controlled and definitive endoscopic therapy is done. Antibiotics are given prophylactically to prevent infection since cirrhotics are highly prone to infection, and so this improves mortality. Ceftriaxone 1 gram IV can be given to be repeated in 24 hours. We could go for balloon tamponade with either Sangsteak and Blakemore tube or Minnesota tube to stop bleeding temporarily. But the definitive management is urgent endoscopy, which is diagnostic and therapeutic. The endoscopic therapy options include endoscopic variceal ligation, where the variceal blood vessels are banded with small rubber bands to constrict them and stop bleeding. Sclerotherapy involves injection of sclerosant into varices to shrink them. We got a monitor here for rebleeding, hepatic encephalopathy, renal failure, and infections like spontaneous bacterial peritonitis. Pantoprazole is not used to treat variceal bleeding, but it is often empirically given for upper GI bleeds until the source is confirmed. It's useful in peptic ulcer-related bleeding, which is a common differential diagnosis of hematemesis. In upper GI bleeding, pantoprazole is commonly started until endoscopy confirms the varices. Pantoprazole is given as IV 80 mg bolus, followed by continuous infusion 8 mg per hour for 72 hours. Once variceal bleed is confirmed, it is not required unless there's a coexisting ulcer or gastritis.
Perla, get Robbie in here.
Hey, Peggy, where's Robbie? Thank you. Robbie, MTP from bleeding varices and trauma. Dr. Robbie.
Yeah, my hands are a little tied up at the moment. I'll need the Minnesota box. Who's in there?
Dr. McKay.
Tell her to go ahead and get set up. She knows what to do.
Minnesota box refers specifically to a Minnesota tube. This device is used to treat bleeding in the esophagus and stomach, particularly from esophageal varices, like the case of hematemesis.
I'll be there as soon as I can.
Yeah.
Much better.
Hemorrhagic shock from varices, failed medical therapy.
Suction stopped working.
Because your canister's full.
I'm on it.
This happens a lot, especially in the ICU. We suction the patient and all of a sudden it fails to work, and we don't realize that the suction is already full. Also, that's a lot of blood loss from the hemorrhage.
Oh my God.
Someone please take her out.
Mom.
Thank you very much. By the way, that is not how you raise patient satisfaction scores. Okay, Dr. McKay, do you want to explain to Javadi here all about the Minnesota?
The Minnesota tube is a specialized tube used as a temporary emergency measure to control bleeding from esophageal varices, especially when pharmacologic management like octreotide fails. It's a 4-lumen tube which has 2 balloons, one for the stomach called gastric balloon, which compresses the gastroesophageal junction, one for the esophagus called esophageal balloon, which, when inflated to apply pressure, causes direct compression of esophageal varices, hence providing the tamponade effect to stop bleeding. Additionally, it has 2 suction ports to remove blood from the esophagus and stomach, preventing it from being aspirated into the lungs. We insert the tube via the nose or mouth and advance it into the stomach. Then, we inflate the gastric balloon first with 250 to 300 milliliters of air, which pushes up against the lower esophagus, compressing varices at the gastroesophageal junction. We apply gentle traction so as to anchor the tube in the gastroesophageal junction tight. We then inflate the esophageal balloon to a pressure of 30 to 45 millimeters of mercury to provide direct tamponade on the bleeding esophageal varices.
So, best way to stop the bleeding is direct pressure. First balloon goes in the stomach as an anchor. Second runs the length of the esophagus with direct pressure on the varices.
First, we want to inflate the balloon underwater like a bicycle inner tube to check for any air leaks.
We want to make sure when it is inflated, there's no gush of air leaking so that the tamponade effect on varices will be strong enough to completely obliterate the varices and stop bleeding.
Javadi, subcock in the port.
Is that 50cc syringe?
Suction's good and running.
I got it. Hey, go on. Langdon called the main line.
You gotta be kidding me.
Princess answered, told me you were busy, just wanted you to know.
Okay, noted. Thank you.
You see anything?
I don't have to.
Just have to push the tongue out of the way in order to pass the tube.
Okay.
The prerequisites for Minnesota tube insertion is that first the patient should be intubated ideally to protect the airway from aspiration of blood. Suctioning should be continuously done on the side to clear the blood as much as possible from the mouth. Then we insert the tube from the mouth or less commonly through nostrils. From the mouth we insert it down the tongue into the oropharynx and the esophagus and confirm that the tube is in the stomach. We can confirm via auscultation of bubbling sounds when air is pushed via the tube via syringe. We can also aspirate blood to confirm this. Only then we inflate the gastric balloon and never the esophageal one first.
Here we go.
Heart rate's 124, BP still only 84/42.
Bleeding is still brisk.
The patient is still in severe hemorrhagic shock here. Lost blood needs to be replenished via transfusion.
Get another unit on that infuser, please. How far did you go?
50 centimeters.
The typical insertion depth is 50 to 55 centimeters from the nostrils or mouth, so the tube should be inserted until the 50 centimeters mark is reached. This places the tip with the gastric balloon properly within the stomach.
Dr. Robbie?
Did you say 50 centimeters? Yes, that's plenty. Inflate the gastric balloon. Start with 50, and then we'll check the placement of the stomach with an x-ray.
As said before, after being sure that the tube is in the stomach by auscultating for bubbling sounds after pushing air or aspirating, which is not shown here, only then the gastric balloon is to be inflated first with 50 milliliters of air. The balloon placement is to be confirmed here with X-ray to ensure that it's in its intended place. Then we increase the inflation to around 250 to 300 milliliters to progressively exert pressure at the lower esophagus, compressing varices at the gastroesophageal junction. We also apply gentle traction or pullback until resistance is felt so as to anchor the tube in the gastroesophageal junction tight. We then inflate the esophageal balloon to provide direct tamponade on the bleeding varices.
Why is Dana still here?
She refuses to leave. That's perfect placement.
So the X-ray has confirmed that it's in its intended place in the fundus of the stomach, just below the gastroesophageal junction. We now inflate the gastric balloon from 50 till 250 to 300 milliliters of air. Then we pull it to apply gentle traction so that it gets anchored in the gastroesophageal junction tight. We then inflate the esophageal balloon to a pressure of 30 to 45 millimeters of mercury to provide direct tamponade on the bleeding esophageal varices.
She wants to finish your shift.
Of course she does. Never met a charge nurse who wasn't a stubborn bitch. Okay. In an adorable way, of course.
I honestly don't know what we'd do without her.
The mouth's filling up again.
Dr. Robbie, we need you in trauma too.
It's difficult to manage everywhere as an attending, and even difficult if you are a resident down.
Yeah, okay. I'll be right there. She's still bleeding higher up in the esophagus.
Natalie.
Got this?
Keep your eyes open.
We got it.
Take-
Perla? Yeah. She's not bleeding in her stomach. We have to inflate the second balloon up in the esophagus.
The esophageal balloon spans the length of the lower esophagus, so inflating it to a high pressure would essentially seal tight the esophageal lumen there, along with providing direct pressure to the bleeding varices, essentially obliterating them to stop bleeding temporarily.
Dr. Robbie.
Yes! I'm coming. Langdon.
This port is in the esophagus.
Along with two balloons, the Minnesota tube contains two suction ports, one for esophagus to drain blood from above the esophageal balloon and one for stomach to drain blood or gastric contents in the stomach.
With a ton of blood.
Mystery solved. Pump up the esophageal balloon to 30 millimeters mercury.
That's an insufflator and a manometer.
Yep, just like a fancy bike pump.
We're essentially pumping air from the outside into the balloon, and we can go till 45 millimeters of mercury.
We are at 30 and shut the stop cock.
Barely any blood coming from the esophageal port. The balloon stopped the bleeding.
We should note that this is just temporary emergency rescue measure to stop massive bleeding from varices. The definitive management is endoscopic therapy, which is both diagnostic and therapeutic for varices.
Tomorrow, GI can cauterize the veins.
No, cauterization is not a primary method for the management of esophageal varices. Esophageal varices are fragile and thin-walled venous structures. Cautery or thermal methods carry high risk of perforation and are ineffective due to the nature of venous bleed-in. These methods are more appropriate for arterial bleeding like in peptic ulcers. The two main endoscopic treatments include endoscopic variceal ligation and sclerotherapy. In endoscopic variceal ligation, a flexible endoscope is inserted and rubber bands are deployed around the bleeding varices. This causes thrombosis and fibrosis, obliterating the varix. It's effective, quick, and can be repeated every 1 to 2 weeks to eradicate varices completely. If this isn't feasible due to massive bleeding, sclerotherapy can be done, which involves injection of sclerosant like sodium tetradecyl sulfate or ethanolamine directly into or around the varix. This causes thrombosis and fibrosis, obliterating the varix. The patient has to be monitored after for rebleeding and hepatic encephalopathy, which can be precipitated due to the GI bleed. More blood means more protein, which means more amino acids, which means more ammonia formation during the process of deamination. Too much of ammonia, which doesn't form urea due to cirrhotic liver, can enter the brain and cause encephalopathy.
That was awesome.
I learned from the best.
So, what happens next?
Once she's stabilized, the GI specialist can do an endoscopy to try to cauterize the bleeders.
Again, it's not cauterization which is done, and it's not a primary method for the management of esophageal varices, as there is high risk of perforation, and it's ineffective for bleeding veins that are thin and fragile, unlike arterial bleeding. The endoscopic treatments she'll likely receive include either endoscopic variceal ligation and sclerotherapy to basically cause thrombosis and fibrosis and obliteration of the variceal vessels and stop bleeding once and for all.
Or they might put in a shunt to take pressure off the bleeding veins.
Again, TIPS or transjugular intrahepatic portosystemic shunt is a rescue therapy and not the definitive management. It decompresses portal circulation by creating a shunt between portal and hepatic veins by interventional radiologists. It's used if the esophageal varices are refractory to medical and endoscopic therapy, like multiple band ligations or sclerotherapy failure, and if there is massive uncontrollable variceal bleeding refractory to every other measure. With this procedure, there is also risk of hepatic encephalopathy, as the shunt now bypasses blood from portal to hepatic veins without the blood products like ammonia being converted to urea in liver. This increased ammonia passes through the blood-brain barrier and causes swelling and dysfunction of brain cells, leading to encephalopathy. So endoscopic therapy is the mainstay of treatment here.
And she'll go to the top of a transplant list for a new liver?
The top of the list? It's that serious?
It is, yeah. But, Once she gets her new liver, she should be able to return to normal life.
Liver transplant is the definitive treatment for end-stage liver disease, most commonly caused by cirrhosis, especially decompensated cirrhosis with ascites, variceal bleeding, like in this case, hepatic encephalopathy or jaundice would require liver transplant. Other indications include hepatocellular carcinoma or acute liver failure.
Okay. I guess I always knew that this day would come, but somewhere in the back of my mind, I hoped that maybe it wouldn't.
It's a lot for someone your age to handle. Is there anybody we can call, or?
Oh, no, it's just us. It's been that way for a long time.
I'm sorry. That's really hard.
Yeah, it's good she has you.
Yeah, I'm the same age that she was when she first got Hep B.
So the relevant risk factors for a hepatitis B infection would be unprotected sex with an infected partner, common with multiple sexual partners. There could be parenteral or blood exposure with IV drug use when the patient shares needles with an infected person or with blood transfusions. Also, there could be occupational exposure with infected needles to healthcare workers or lab personnel. There could be household contact when living with a person who is chronically infected and sharing personal items like razors, toothbrushes, or nail clippers.
I know it's hard to believe when you look at her, but she was a wild child and an intravenous drug user.
The risk of transmission of HBV from needle stick is 6 to 30% per exposure of a source, which is HBe antigen positive. HBV is highly infectious and survives for at least 7 days on surfaces, including needles and syringes, so sharing needles can easily transmit infected blood from one person to another. Also, HBV is 50 to 100 times more infectious than HIV, so even tiny amounts of contaminated blood can cause infection.
But she got clean the day that she found out she was pregnant with me, and she has been ever since.
She sounds like a good mom.
She's the best. Are you close with your mom?
Sure, yeah. Like proximity-wise. It's just not the first word that comes to mind. It's complicated.
Usually is, right?
Yeah.
I mean, my mom hasn't been perfect. I mean, sometimes I really hated her.
Familiarity breeds contempt. Forget parents. If you start living with someone for certain years, you will start hating that person's habits eventually. Regarding parents, you'll realize the importance of your parents once they're no longer with you or they're forever gone from this world. So, hate is just such a strong word to use for someone who want nothing but the best for us, unless of course there is a very big and strong reason to dislike or something, which are exceptions. So, I don't really resonate with the younger generation of kids who openly and just casually say they hate their parents without even understanding what the word hate really is, and without understanding their parents want nothing but the best for them.
But I always loved her. And I knew that she loved me.
Yeah, it's a long road ahead, but it's a marathon, not a sprint. All you can do is take it day by day. We have a great social worker here, Chiara Faro, if you want to talk to her.
Family members of the patient who've gone through a lot with the patient also need psychological counseling and reassurance, or else depression-like symptoms can take over. It would be overwhelming to a young family member to be witnessing their beloved struggle for life.
Maybe a little bit later. I think I just want to be with my mom right now.
Yeah, of course.
Yep. I know.